The brain is only a few pounds or maybe 3% of our body weight, but it's utilizing a quarter of our metabolic energy. So it's burning micronutrients faster than any other organ. So every single nutrient is critical for brain function. And it's really important.
I gotta get myself a little more faith, a little more love.
I'm your host, Christa Bigler, and I'm going to guess we have at least one thing in common, that we're both in pursuit of a less stressed life. On this show, I'll be interviewing experts and sharing clinical pearls from my years of practice to support high-performing, health-savvy women in pursuit of abundance and a less stressed life. One of my beliefs is that we always have options for getting the results we want, so let's see what's out there together. All right, today on The Less Stressed Life, I have Dr. James Greenblatt with me, who is a board-certified child and adult psychiatrist and a pioneer in the field of integrative medicine. Since 1988, he's helped patients through a personalized nutrition-based approach to mental health. He completed his training at George Washington University and fellowship in child psychiatry at Johns Hopkins, and currently serves as an assistant clinical professor at both Tufts and Dartmouth medical schools. Dr. Greenblatt is the author of 8 books, including the best-selling Finally Focus, the breakthrough natural treatment plan for ADHD, which when I read this in his bio, I was excited because I didn't know that this book existed. I just had his Anorexia book. And then I think he's got 2, but I'll let him correct me, but Answers to Anorexia, which was updated in 2021, and his newest book, Functional and Integrative Medicine for Antidepressant Withdrawal. He's also founder of Psychiatry Redefined, an educational platform advancing evidence-based integrative psychiatry. Welcome to the show, Dr. Greenblatt.
Thank you, Christa. It's good to be with you.
Yeah, so I already told him offline, why did I invite you to this show? So we had Erin Falco, who is a dietitian, here a while back. I don't remember exactly when. Our topic was so fascinating, and she spoke at a dietitian conference I was at. And I think why I loved the presentation is I love case studies. I love a good case study. Tell me the results that you see. Please don't just tell me what your research is, but how it applies clinically. So I know that she learned and gained so much from you. I'm actually not sure how your relationship started, but what I think is interesting to me out the gate with you is that this all started since 1988. You've been looking at nutrition as a part of psychiatry, which if you started to do that now, I feel that it would be progressive. So in 1988, you were like on a different planet, perhaps. So I'd love to hear how this somewhat started. How did you get into this topic? How did you bring nutrition into psychiatry?
Some might say it started in 1980. So in college, I just had this interest in nutrition and brain function. I did papers on what was called orthomolecular psychiatry, which is high-dose vitamin B3 for schizophrenia. And I was interested in the integrative medicine world. I went to medical school thinking I was going to cure the planet with kale and brown rice. And that was before people were eating kale. And then going through medical school and as a child psychiatrist, I came out prescribing meds for children. I was a psychopharmacologist, and it only took a few years in practice to realize why I went into medicine is to understand the role of diet and lifestyle. And since the 90s, I've been able to not only learn the material, but teaching has been a big part of my career since 1990.
Yeah. Okay. So you are interested in nutrition. It makes sense, right? What we value, we tend to step forward with. I'm guessing you had a little pushback. We don't have to cover all of this uphill battle that you may or may not have had since the 80s, but I'm curious, where did you start in college? You were digging into things at that point. Was there a lot of literature for you to draw from to allow you to implement nutrition therapy into practice immediately at that time?
A really good question, because I remember in 1993 giving my first talk to the community. There was like 200 people in the audience on ADHD. And at that time, I remember having to say that we have no research to support ultra-processed foods and sugar affects behavior. But, and then I went to case studies and what parents share and what we knew. But I remember that line. I have no research because at the time, pediatricians said refined sugar and ultra-processed foods are fine. And now we have scores of research looking at ultra-processed foods affecting depression, anxiety, even cognitive decline. So the research was minimal, but there's been a community now going back 60, 70 years that have been looking at integrative and functional medicine for mental health. So I've been able to practice and I think bridge both worlds of traditional psychiatry with the integrative and functional world. And patients just got better, and it just reinforced the work that I was doing at that time. Now the research has exploded.
I want to start actually with a story or two, whatever kind of sticks out to you. And I know that there's probably hundreds, if not thousands of stories, but maybe since we're back in the 80s right now in this conversation, you said you gave that first talk on ADHD, but what did it look like when you started giving nutrition? Do you remember some of the things that happened as you started implementing nutrition? Then I want to get a little bit more granular as well, but I love stories, right? So tell us what it looked like.
Yeah, lots of stories, hundreds, if not thousands. And they all started with, if we take ADHD, might be the simplest, and then we'll move on. But with every disorder, parents coming in, one parent saying, medicate my kid, and the next parent and saying, I don't want medicines. And the approach is always the same. Medicines aren't evil, but let's look at nutritional deficiencies first. And by doing some simple tests, we're able to help determine if there is a nutritional deficiency affecting the behaviors, or if there's a hormonal problem or a gut problem. So we're always looking early in the career is looking at objective data. So I'm not just throwing supplements at patients. I'm saying your child has a deficiency of magnesium, or you're coming in with a history of depression and we check and you have very low vitamin B12. So the stories were just adding simple micronutrients based on the testing. So B12 completely reversing depression. Vitamin D levels are so important for brain function, but aren't routinely checked, certainly not 20 years ago, by psychiatrists. So I can have scores of depressed, I had bipolar adolescents with very low vitamin D levels. The most common nutritional deficiency we see is magnesium across mental health practices. So we have kids sleeping better. So it's just a model based on objective laboratory testing, working towards an individualized path of utilizing micronutrients to treat mental illness.
So something interesting that you say is that you were doing testing. And I would say that we have opportunities for testing around every nutrient you just mentioned. B12 for sure. That's an easy one. Vitamin D, also easy. Magnesium, zinc, it's not going to be common. In fact, I remember when my mother was in the ICU in 2021 and I asked for a vitamin D and they could not find it in the testing, which was quite disappointing for me, actually. But I would say that I feel that nutrient testing is not as straightforward as showing up to the provider and saying, will you test my nutrients? Because it's not commonplace, even to have a B12 checked or a vitamin D checked even though those are, I think, quite easy to get, they're not super common. And so I'm curious, I have two questions. Did you have more access to more testing? I don't know if you were affiliated with a university at that time, which may or may not have allowed you to have more access, or did you feel that it actually was quite accessible? So that's the first question. And then I want to ask if with magnesium, you were checking red blood cell magnesium or something else, and with zinc, if it was plasma zinc or some other way.
Well, let's start with your comment, vitamin B12 and D. These are simple tests. They are occasionally done. The implications for completely transforming our mental health treatment model is just staggering and profound. And nobody's looking at it. Mm-hmm. And they should be done in every patient with a mental health illness. For me, I was fortunate. I was the chief medical officer at a facility, at a hospital for 25 years, where I was able to say, we're drawing these bloods on everybody that walks through the door. And then
That's always helpful.
yeah, it makes it a little easier. And we could see the tremendous. In my outpatient practice, I wouldn't see somebody. I don't think it was ethically for me to see a psychiatric patient and not understand those two markers, because I could completely reverse major mental illness. Not with everybody. Some people have normal B12 levels, but if we get a B12 level of 120 and 200 or even 300, and somebody says that's normal because the lab slip said normal, I've completely reversed someone's depression by giving them B12 shots. So these tests are available. They're covered by Medicaid, Medicare, and most insurances. And it just really is important that both the consumer and clinicians just make sure it happens.
I have to make a comment there. I know we have several questions tucked in here. Welcome. Welcome to how I sometimes answer questions. Don't worry, I can re-ask them. You just mentioned something I want to highlight and underline, because every time we get into a conversation, it's like, here's the pieces, right? It's like when people come to me and they say, I just had blood work. I'm like, I bet you had $3 worth of blood work. All right, so go and ask for these tests. I've been in private practice for 10 years, and then I did dialysis for about 8 years before that. And in the time that I used to do a lot of nutrient testing. Actually, this conversation takes me back to the nutrient testing that I had at that time. It was very fun to do because we got to see lots of results. But the point is, when you go to the doctor and when you ask for B12, I'm disappointed by how the reference ranges are declining. And the current lab I'm using, the reference range, the low end, I think is 252 to 1200. And you just said 100, 200, or 300. That would show as normal, right? If someone was at 300. For me, if it's under 500, I think it's too low. I don't think that with B vitamins, I don't think there's a negative to trialing the supplementation because it's water soluble. So I'm curious for you, for me, it's 500 is too low. What's too low for you?
I've used that term 500 for 30 years. And I can't tell you how many, what I would call tragedies, where people got their B12 levels, had the 310s, were told it's not B12, and we saw them 3 years later, and B12 reversed these conditions. And I've waited 30 years, and a new research paper did come out in the last 3 or 4 months looking at these numbers between 3 and 500 and demonstrating that there were cognitive decline and other symptoms in that range. So a new study that just came out that put a little emphasis on what you're describing.
And I will also mention, anytime someone has a low B12, I always like to talk about how that's upstream. It's a digestion problem. It's an animal protein problem. We'll get to that as well. B12 is found in animal products, so you have to digest it and then you must absorb it. And I would be curious what you think about this. I know you have I believe you spent most of your career with children, but they say that the aging population is known to have low B12. And I can't help but wonder if it's just the same things aforementioned, where it's digestion and absorption, or is it because there's something happening in aging where they have less intrinsic factor? I don't know, where they're not absorbing it. So that's a comment for you to comment on if you want to. And I will also mention, you just mentioned mental health around B12. I want to just offer that B12 is a nutrient for fatigue, 100%, and a very common, it's not always, but it's a very common side effect when your B12 is low is maybe extremity tingling. And I just remember a story of a young woman one time who had really low B12 in my practice, and this is what happens to humans. Her grandfather had a heart attack, and so she was having tingling extremities, and her brain was going to, I'm going to have a heart attack. And it was just low B12. And so I'm sure you have all kinds of stuff like that, but I really appreciate you saying that. I think this is like a very common tragedy, most likely also with B12. And so, yeah, any comment about the aging population having more?
Yeah, no, it's critical. I bring it up in almost every lecture, because what happens is when we age, and aging for the digestive system can start at age 30, we less hydrochloric acid. And so it's really pretty significant. So acid in the stomach starts the whole digestive process for protein and helps start the digestive process for vitamin B12. So decreased stomach acid we see with people taking antacids, which most of the planet taken. We see with aging, and we also see with chronic stress and PTSD, so low stomach acid, and also zinc deficiency. So there's lots of paths where we can determine some of the underlying causes for vitamin B12 deficiency. Sometimes, as you mentioned, it's dietary, a vegan or vegetarian might not get adequate vitamin B12. Other times it's more functional. There's just low stomach acid.
Yeah, I would say I have a very health conscious population, and I'm not sure if anyone has great stomach acid because of stress and probably nutrient cofactors. I just share that because I make jokes that they can put on my headstone that no one was digesting very well. So I have strong feelings about that. Okay, so we're talking about B12. We're talking about that as a really key point. And I feel like this is just a good time. I'm going to go back to all those. I will 100% go back to talking about testing of magnesium and zinc. But since we brought up dietary factors around vegetarian or vegan diets or not having animal foods, something I've observed with interviews and with people for a long time is that when we're not digesting animal proteins, we're not getting not only B12, but also amino acids, which make up neurotransmitters. And it sounds like you may have some similar beliefs around what's the research related to health implications with vegetarian and vegan diets.
Yeah, the big picture is, and sometimes hard to say in an audience, is we have higher rates of anxiety and depression in vegetarians and vegans. And we have lower rates of some important micronutrients like zinc and B12. I think what's been critical to me practicing for so many years, it's really not the diet, because we can have 3 vegetarians and one would have absolutely perfect amino acids, one would be low, and one would be undetectable, very low. So it's really, and that's why the objective testing is so important. But low levels of amino acids, fasting amino acids, has been, as a psychiatrist, one of the most important tests that I've done, particularly for symptoms of depression, fatigue, and anxiety.
How are you testing amino acids, fasting amino acids? Is this?
And these would be plasma blood tests. There are urine tests, not as helpful, but some people do them. But these are fasting plasma amino acid tests. And I remember exactly when I started doing these tests because I checked the box by mistake in the 90s. And I got this test back and it didn't make sense to me. What if someone had steak for dinner last night? What if someone had a salad? Then wouldn't that affect their plasma amino acids? But it really doesn't. It's a steady state. And regardless of dietary intake, some patients have low levels and high levels. And it usually is the result of adequate digestive enzymes and hydrochloric acid.
Yeah, back to that same story. We all need to digest
Always.
better. Yeah.
Yeah.
Okay, so we started with the B12. I don't know if we need to cover vitamin D testing because it's pretty simple, pretty straightforward. But let's talk about about magnesium and zinc testing, because I don't feel that's probably going to get done without very specific request or self-ordering for most humans if they don't have access to someone who has ordered that before. So with magnesium, there's different ways to do different things. So that's why I was wondering if you did red blood cell magnesium, a different type of magnesium, and then plasma zinc or in some other way.
Yeah, magnesium and zinc are unique. And the punchline is there's not one test that's going to help you as a clinician. So I look at RBC magnesium. Serum magnesium is useless unless you're on dialysis or in the ICU. So most people, so I do an RBC magnesium and often look at trace mineral magnesium in a hair test. But 99% of our magnesium is in our bones, in our tissues, and our cells. So we don't have a good way of assessing magnesium, except for a good clinical history. So we have physical symptoms that reflect magnesium deficiency. And I learned years ago this phrase, if it's spasms, think magnesium. And if you think of any disorder, whether it's asthma, lungs, migraines, interstitial cystitis, muscle twitches, those are all magnesium deficiency kind of syndromes. If you think of Anxiety, constipation, insomnia are probably the three most common clinical symptoms of magnesium deficiency. So there's not one great test, but if you look at some of the tests and you look at the clinical symptoms, I assure you clinically, if someone walks into the office that is not sleeping well, anxious, constipated, they are going to feel a lot better with magnesium.
And how I totally agree with you. And I find that I'm mostly doing mineral analysis for magnesium. And I think that there's an order to supporting minerals. And also, most people feel better or symptomatic relief when they trial magnesium in general, is what I've seen, to your point. My understanding is it's very slow to replete. And so I'll share a little bit of a story. I remember once upon a time when I was doing lots and lots of comprehensive micronutrient testing, and I had a really cool mentor from Texas. He was great. He tested lots of athletic teams, and so I could always call him and ask for what the actual clinical dose of that nutrient that would make a difference was. And I remember talking to him about my twitching eyelid and how I knew it was magnesium deficiency and how annoying it was. But it would happen after I would drink too much coffee. And I share this because it was increasing my cortisol and my stress. It was just part of how I was at that time. And I share that because stress is also depleting our magnesium. Maybe you have some other comments. But my question or comment I'd like you to comment on is that I understand that magnesium is really slow to replete. And I tend to recommend topical absorption of magnesium quite a bit, and I've had a lot of success with it. What do you see about, like, the reference I've been given is that it can take years to replete magnesium. And I think part of the conversation, and I think this is the conversation with hydrochloric acid and digestion as well, it is how much stress are you putting in? So how much are you depleting or dumping out is how I think of it. But I'd love to hear what you think about repletion overall, because I think you need to support much longer than the symptoms subside.
Yeah, no, I use topical or magnesium sulfate baths as an adjunct, but I still do the pills, usually magnesium glycinate. And it can take a while. Sometimes we see improvement in some of the symptoms more quickly, 2 weeks, constipation, 4 weeks, sleep. But oftentimes it can take a while. And sometimes for magnesium repletion, you need B vitamins, B6 in particular. I do agree that it can take time. And I use a combination of topical and supplements, pills.
Okay, so far we've talked somewhat about D, B12, zinc, magnesium, and I want to make sure we cover, I feel like we talked a little bit about amino acids. I feel like all nutrients could be brain nutrients, but I want to talk about any other really common nutrient deficiencies you're seeing that are influencing brain health. What are we missing? You touched on just a little bit B3 at the very beginning and B6, and these are, I feel, again, not easy to test. I know that they were accessible for you, which I love, but so what other nutrients are we missing in brain health? And then any comments about testing around them?
Yeah, I think we just need to assume every micronutrient is critical for brain health. Let's just put it in perspective. If the brain is only a few pounds or maybe 3% of our body weight, but it's utilizing a quarter of our metabolic energy. So it's burning micronutrients faster than any other organ. So every single nutrient is critical for brain function. And it's really important. Some of the big ones that we see that we haven't talked about would be zinc. I've read, although I haven't seen the reference, that every enzyme in the brain requires zinc. And zinc is critical to make the neurotransmitter serotonin, also to make melatonin to help us sleep. So zinc is critically important. And zinc is primarily in animal foods. So our vegetarians sometimes can be deficient. And we see low zinc. Actually, I see a lot in addiction. I see a lot in my eating disorder patients. I see a lot in individuals that are doing the sweating yoga or the hot yoga and in a sauna, because we lose zinc through sweating. So zinc deficiency is common. Probably the most common path that we see it in kids is elevations of copper, like copper water pipes. So copper is common and it just forces zinc down. So zinc is critically important for brain function. And probably the most important micronutrient that I've used in my practice, that I've been teaching about, that I think is by far the most helpful, is actually lithium, the nutritional lithium. It is not prescription drug lithium. It is the micronutrient that's critical for brain function.
Let's talk about that one a little bit. I have about 12 questions from your little comment there, but let's talk about lithium first since you just dropped off there. Will you describe lithium to us? That was something I never really used in practice because one of my mentors said, you never want to mess up lithium. And I like that you just differentiated for a moment that there's prescription or medication lithium and then nutritional lithium. So can you just unpack lithium a little bit for us, why it's essential and how it supports brain health?
Sure. In our training program, we have a 2-day workshop, 16 hours on lithium from experts around the globe. So it is just a critical micronutrient particularly for brain health. But let's think of lithium as an element. It's in the periodic table. It is in the rock, in the Earth's crust. And we use this mineral, I think as everyone knows, lithium batteries, cell phones, we use it in airplanes, and we use it to make fireworks. And most technology requires a small amount of this element, lithium. And then we can put a lot of that element with a cofactor called carbonate, and we have a drug, a medication called lithium carbonate that's used for bipolar illness. And we use it at doses of 900 and 1200 and 1800 milligrams. So we have an element that's in our rocks that gets in our water supply. Now we have a drug that's made by pharmaceutical companies. And in my world, my entire career is focused on what's in the middle, adding milligrams of lithium, 2 to 20 milligrams of lithium as a therapeutic agent for mental illness. And I have more research to support these low doses of lithium than I do probably of any other micronutrient and the vast number of medications that I use as well.
Is there any negative to the 2 to 20 milligrams of lithium? And are you testing lithium deficiency?
The average people get in their water supply might be 2 to 4 milligrams of lithium. But depending on where you live, the amount of water varies. And just the amount of lithium in your water, whether it's tap water, it varies. The studies we have from around the globe, 20 different communities in Texas, 10 different communities in Japan, they all have different levels of lithium. And the lower lithium in the drinking water, we've demonstrated year after year, study after study, one meta-analysis at over 3 million patients. The lower lithium, higher rates of suicide, dementia have been studied the most. Other studies looked at psychiatric admissions and violence. It's that dramatic. And higher levels, if you happen to live in an area with high lithium, or you take a drive to Lithium Springs, and there's all over the country, there's one in Georgia, some in Texas, some in Canada, these lithium springs that people drink the water, lower rates of mental health and mental illness. So it's pretty dramatic, and the research is there.
So people are going to want to know, how do I find out if I have lithium in my water?
In past winters, my son has gotten dry hands that can crack and bleed. I found that giving him at least 300 to 600 milligrams of high-quality fish oil really resolves this in a few weeks. This year, I started him on Jigsaw's Alaska cod liver oil because it's the best value for high-quality U.S.-sourced cod liver oil. Just 1 teaspoon gives him 1,000 milligrams of total omega-3s, which just means faster results with nature's natural dose of synergistic vitamin A and D already found in cod liver oil to support immune health. Jigsaw sources their cod liver oil from Alaska, where line-caught fish are flash frozen on the boat. This keeps the fish oil very fresh, so it doesn't require more processing and deodorizing like other fish oils, which can disrupt the oils and nutrients. So when you combine Jigsaw's incredible cod liver oil with some of their other wonderful electrolyte mineral products, it's a winning combination to keep your skin beautifully hydrated year after year. You can get a discount on all of Jigsaw's products, including Alaska Cod Liver Oil, Electrolyte Supreme, Adrenal Cocktail, and Potassium Cocktail, formerly known as Pickleball, at jigsawhealth.com with the code LessStressed10, which you can use on each and every order. That's code LessStressed10.
If you go on the geological surveys, the U.S. maps, you can look at county, you can look at your water, you can test your water. Now, the problem is, of being an old person, I've been looking at this for 35 years, before everyone was obsessed with bottled water. And we look at hair samples. And when I did this 30 years ago, up until the last 10 years, I had maybe 25 to 50% of undetectable lithium in the patients I was seeing. Now it's much higher because everyone's drinking bottled water, which is filtered and probably doesn't have the natural lithium. So it's an increasing concern. And you asked about toxicity. So if I come up with this 2 milligram as the average people get, and so I'm quite convinced, using this for 30 years and reading about it for 45 years, that 2 to 5 milligrams is completely non-toxic and safe. You don't get a blood level, and there's probably some clear benefits in terms of preventive cognitive decline. And then as you get higher, it's used as a therapeutic tool.
Is that the only difference between prescription lithium? Is it high dose, or is there some kind of synthetic component?
No, and that's why people are arguing about the supplement lithium orotate versus lithium carbonate. And it's just a carrier molecule. Lithium is lithium. And the most important thing people should understand is the amount of elemental lithium is what we're comparing. So you're going to be careful with companies. It's not always listed as the amount of elemental lithium, but that's what you want. And that's why, to me, 2 milligrams is a physiological dose.
So prescription lithium is just a very high dose of
Correct.
lithium carbonate.
Yep.
Okay. And what happens if you get too much lithium? If someone goes on, and it sounds like you can test it in the blood. You mentioned it in there.
You can test prescription lithium because then you get a blood level. You should not have any blood level by taking lithium orotate, over-the-counter lithium, the 2 milligrams. You should not have a blood level. And I've never seen side effects on 2 milligrams, on the 5 milligrams. I've had people say they felt too calm and they didn't like it. And as you get higher doses, sometimes you can get headaches and irritability. But rarely, again, almost 40 years now using nutritional lithium, that 2 to 5 milligrams, I have not seen side effects at all.
Is prescription lithium mostly used for anxiety, or is there other indications?
Prescription lithium is primarily used for bipolar illness, a significant major mental illness that it's incredibly helpful. I try to get people off prescription lithium quickly. My colleagues who keep them on longer, they tend to be more side effects, and you can actually get kidney damage and thyroid damage if you stay on high doses for too long.
That's always the good conversation to have, is that most things are a little bit Goldilocks. I would say B vitamins and vitamin C, not so much Goldilocks since they're water soluble, assuming your emunctory functions are working properly, but some other things I always like to question. And actually, that does take me back to vitamin D really quick before we go back to zinc. There are arguments back in the day, and it wasn't that long ago. They probably still do this. They were doing 50,000 IUs of vitamin D2, and then they decided maybe we should give vitamin D3. And anyway, we don't have to slice and dice too much about how people dose vitamin D, but coming from your position, there's lots of ways to think about vitamin D because it's fat soluble. You could take a loading dose. You could just take it once a week. And so I'm curious how you handle vitamin D maybe in practice. And then do you retest after a certain amount of time?
Yeah, absolutely. Retesting is critical, and testing to know what to do is critical. So in a mental health practice, we see patients who have levels under 10 and significant vitamin D deficiencies. So I would give 10,000 international units of D3 for usually 1 or 2 months and then retesting. The core part of my career and practice in functional psychiatry is this concept of biochemical individuality. Everyone's different. So I could have 10 patients with a vitamin D of 10, give everyone 10,000 international units. And if I retest everyone in 2 months, somebody's going to go up to 60. Someone might go up to 40. Someone might only budge to 30 because they might need magnesium or other cofactors. So the testing and the retesting is really essential because particularly if someone's low. For maintenance, it's a little easier to say, take 5,000 international units with vitamin K2. But for a deficiency state, you want to give high doses and then retest to know how they utilize and absorb vitamin D.
I'm glad you mentioned the K2. I was going to ask you that, so you covered that. If you do not take vitamin D3 with K2, at least your calcium can get displaced. I'm not sure all of what else can happen, but okay, cool. Let's go back, and that makes perfect sense, and I'll share that I think the generally accepted reference ranges are that under 30 is low for vitamin D. So when he says 10, I would say that is atrocious. So that's how I feel about that. I would agree that I'm guessing that the symptoms are severe at that point. So I wanted to ask you, we talked about how magnesium testing isn't really accurate because of where magnesium is stored in the body. I think these are these little technical nuanced conversations that must be had because when we say testing, it's not exactly straightforward for people. And so I want to ask, do you think zinc testing is accurate?
I think zinc testing is helpful, yes. Particularly working in an addiction clinic. I can't tell you how dramatically low zinc is. Working for 25 years in an eating disorder facility, patients with anorexia, we had low serum zinc. Yeah, we look at lots of different paths to understand if someone needs zinc, but serum levels can be helpful, yes. There is an RBC zinc that to me is not necessarily better because I've just been used to looking at serum and for so many years.
Yeah. Okay, I want to talk about, this is actually how I was introduced to you, was your thought processes and concepts around zinc and disordered eating. And so it's how I would describe it is a little bit of a chicken or the egg discussion. And so will you talk about how the symptoms in disordered eating and the symptoms or zinc deficiency overlap and why? I think this is a huge part of your work around anorexia includes zinc conversation. So let's dive into that just a little bit more.
Yeah, let's just take one step back and share with everyone that anorexia nervosa is the highest mortality rate of any psychiatric illness. So more kids and adults die. And it also is the highest risk of suicide for any psychiatric illness. And we have no treatment that is consistently used anywhere and no drugs that are approved for treatment. So I've spent my career watching too many children die and adults die from eating disorders. And there's a lot of great clinicians are trying. We're trying to feed calories. We're trying to do therapy. We're trying to do this. And many people recover, but many don't. And what was mind-boggling to me 25 years ago when I walked into an eating disorder facility and ending up staying for 25 years as chief medical officer is these young women and young men now were not eating, were starving, and nobody was addressing the malnutrition, right? It was just calories. It was just calories to restore weight. And I was interested 100 years ago in micronutrients and brain function, so I started looking at it. And I just discovered the zinc connection early on in 2000, and it was just overwhelmingly clear that this micronutrient had a profound influence on almost all the symptoms that you and I would call anorexia nervosa. And there was research. And so that's my story, and we can go through some of the mechanisms, but if you want me to just go through zinc and eating disorders in a quick rundown for a minute?
Yeah.
So let's just start with every aspect of digestion. your taste buds are zinc-dependent enzymes. Okay, so if you're zinc deficient, your food doesn't taste well. Whether you have COVID or whether you have your 80-year-old with zinc deficiency and food just tastes terrible, and then you get more depressed. So you don't taste, and that's common. If food doesn't taste good, you're not going to want to eat. We mentioned hydrochloric acid and digestive enzymes. You need zinc to make acid and digestive enzymes. What is the most common thing we see in patients with eating disorders? I don't feel well after I eat. I feel full. I'm bloated. I'm distended.
Yeah.
That is a sign of zinc deficiency. Sleep problems. You need zinc to make melatonin. You need zinc to make serotonin. Anxiety. You need zinc. The list is pretty long. Attention problems, depression. And we've just found zinc to be this and deficient in many of the patients that are coming in. And there was early research looking at providing zinc to patients who did better. And it's simple. It costs pennies. There's no side effects. But ask me how many treatment programs are using zinc supplements for patients with anorexia nervosa.
Yours.
A few, yeah. When I left in the summer, but I don't know if they're still doing it, but absolutely for 25 years. And it's not the complete answer, but it's foundational. Because if their appetite gets a little better, their anxiety gets better, their digestion gets better, we can work with them, also provide other micronutrients that are deficient, but also help the cognitive distortions, the rigidity that gets in the way of recovery in an eating disorder.
Mm-hmm. And everything you just said, I'm going to repeat a little bit. I actually have your slides in front of me from this seminar, and really it's like anorexia symptoms and zinc symptoms, and underneath of it are all the same symptoms. And so you said that in different words, but I'm just sharing. It's if you look up both of them, they're the same. And you mentioned this in passing, and I think it was very useful. You forget when this is passed. For me, I did a little bit, but this was definitely in a lot of our minds around COVID, right? People didn't have taste for things. And it's was it COVID, or actually are you zinc deficient after COVID? And another one of your slides is, again, I'm just emphasizing what you said. I just want to really underline it and highlight it, is that a significant percentage, I'd love to know what you think the percentage is, of your anorexia patients are zinc deficient. You see this on testing. And so this question is when I add the zinc, these symptoms get better. You did mention something I want to just acknowledge, and you offered earlier, you use oral magnesium glycinate. I find glycinate to be generally most tolerated in most mineral types. And so I would recommend zinc glycinate. Also, you may have a different recommendation, but what I will say is that sometimes taking a high dose of zinc can give you a little bit of a stomach ache if you don't take it with food. So I don't know if you use a different form of zinc.
I'm not sure that the form matters as much. I use glycinate, picolinate, but absolutely an empty stomach. Some of these patients will get nauseous and never take it again. So yeah, you always want to take zinc after meals.
And I think there was a slide where I started taking zinc, and after 3 days I had an appetite, but I was scared, and then I felt hungry and I stopped the zinc. So I'm sure that this is a challenge. I think this is the other side of the challenge for you probably in practice.
Yeah, that was actually a medical student who I was working with who was struggling with anorexia. And I just use that slide to remind everyone it's not 100% biological, anorexia nervosa, but the biology and certainly the nutritional deficiencies are completely ignored by our current treatment model.
Okay, I think I can squeeze in a couple of more questions before we've got to wrap up today. And the first one I think is more related, and the other one is going back to fatty acids and phospholipids. Are there medical conditions that mimic anorexia or eating disorders?
There are many, and just like in all of psychiatry, we just think of mental illness as a deficiency of one drug or another. But for anorexia nervosa, probably the two that someone would need to want to understand would be PANDAS, a neuroimmune response to a strep infection or another infection like Lyme. So an immunological response, it looks like anorexia nervosa. They have this distaste for eating. Some kids even refuse to drink water. And the other one, it's not a cause, but it's directly related, is celiac disease. So there's a very high correlation between celiac disease and anorexia, and then patients with anorexia developing celiac disease. And to me, the bridge is the malnutrition. That you stop absorbing these micronutrients, and then you lose your appetite, you don't digest. And then if you're around friends, peers, social media, and you start restricting, guess what? Those with celiac will sink deeper into that eating disorder. So celiac and PANDAS are the two that I just urge clinicians to make sure they address and test for.
Yeah, and most places aren't going to know what PANDAS are. We've done multiple episodes. The audience here will know what PANDAS are, but just as that's also an area where if you ask your doctor and they look at you like you have 3 heads, it's okay. Maybe find someone who knows what what you're talking about. Okay, a couple more. So we've covered a lot of nutrients around brain health, and you hear people talk about the importance of fatty acids in brain health, and I love phospholipids. Is this anything that you consider as well in your practice?
Yeah, it's essential. I think that the research is staggering. Low levels, particularly omega-3s, associated with depression and suicide risk and anxiety and depression. The difference, the confusion part for some of my colleagues is some of the research studies by giving people fish oil, not everyone got better. And it just brings us back to my whole point of biochemical individuality. And we do fatty acid testing on every patient. And not every depressed patient is low in essential fatty acids. But I just saw a woman with alcoholism and depression that they were so low, they were almost undetectable. I've never seen anything like it. But, her roommate, depressed, alcoholic, completely normal fatty acids. So the important point here is the relationship is clear. The brain is 60% fat, and we need these both saturated fats, cholesterol, as well as essential fatty acids. And sometimes testing is the quickest path to know who would benefit from higher dose supplements. I think most of us would benefit from eating a diet higher in omega-3s and small amounts of supplements.
Yeah. And I can understand why omega-3s are deficient because there's not an extreme amount of animal or the type of omega-3, EPA, and DHA that we use. Mostly salmon, maybe algae. Otherwise, you've got to rely on your liver to convert it. And I am a person who does not convert that very well, which means I'm going to be more predisposed to dry skin. And I'm curious how you're testing omega-3s. And I want to offer, there's an omega-3 testing company in my state. They do a finger prick. It's Omega Quant, and it's $50 and really straightforward. And I know the people there, and you may have feelings about proper omega testing. Is there other ways that you do this?
No, I've said many times, if I was at a big practice again, I now just consult Omega Quant would be a perfect path to looking at that. I think most labs look at omega-3s. The routine labs don't do a great job. The Quest and LabCorp, it's hard to make sense of those tests, but a lot of the functional tests look at omega-3s. It's better to do a blood cell versus plasma, and Omega Quant is a good recommendation.
Yeah. So what's really important to me is that all of this work that you've been doing for, 40 years at least, gets continued. So how are we going to continue the work of Dr. Greenblatt and keep and make more versions of you? You mentioned that you have some training programming. So I'm like, well, how are we going to continue this work? Because it feels like you're just getting started.
Yeah, really good point. And as both patients and professionals now appreciate the role of nutrition and mental health and asking for the information. So I have my last book on depression, functional medicine for depression, coming out next year. We just finished that. And the Psychiatry Redefined.org is a training program for all clinicians, but geared towards nurse practitioners and naturopaths and doctors who can prescribe supplements and order the testing. So we're helping train doctors. We have short courses for 4 weeks, and then we have year-long fellowships where people can really change their practice to be able to say that they're an integrative and functional mental health clinician. So that training program, we have some great faculty from around the globe, and that is growing, and that'll continue for a long time.
Great. we'll have to say, I hope that you're marketing to the dietitians because they can do those things as well. Otherwise,
Oh,
all the ones listening-
absolutely.
Otherwise, all the ones listening will be like, you forgot us.
Oh, dietitians have been part of our fellowship since we started 7 years ago. And some of the most helpful comments and support has been from our fellow dietitians.
Yeah, cool. As someone who has a family member with psychiatric issues and conditions, and when I heard about this, I felt very compelled. I'm very glad you agreed to come on the show to talk about this today, just so we can try to spread your message a bit more and even get into that nuance around how can people test and support. And I think you served us very well. So thank you very much. And I hope to have you back to talk about ADHD in the future.
Oh, good. Thanks for having me. Take care, Chris.
Just keep breaking.